Hello, my name is Han Kim. I'm a cardiologist at Duke University and the Duke Cardiovascular Magnetic Resonance Center in Durham, North Carolina. Today I'm going to discuss clinical delayed enhancement CMR imaging, tips, tricks, and emergent techniques. The Duke Cardiovascular Magnetic Resonance Center, or the DCMRC, was established in 2001, and it is a dedicated facility to cardiovascular MRI. Our missions include patient care, research, and education. If you find this webinar interesting, we have a number of educational opportunities, including fellowships, courses, and online opportunities. Visit our website. If you're interested in level 2 cases, you can go to dcmrc.talentlms.com. Last month, we moved into a new facility and have expanded to 3 dedicated cardiac MRI scanners, including 2 3 Tesla scanners and 1 1.5 Tesla scanner. Our expansion, in part, is due to a steadily increasing demand. We, like other centers, have continued to see the need and growth for cardiac MRI, and even in the last 5 years, as you can see in this chart, there has been continued growth. Over the next 30 minutes or so, what I'd like to share are some tips that may help you, as I believe we will all see more and more patients coming for cardiac MRI. Here's a typical timeline for our core cardiac exam with vasodilator stress, which includes cine MRI, as you can see here, stress and first pass perfusion imaging, as you can see here, and delayed enhancement imaging. Today I'm going to focus upon delayed enhancement imaging, which is one of the linchpins of the core examination. In the literature, delayed enhancement MRI is also known as contrast-enhanced MRI, late gadolinium enhancement, or LGE, and late enhancement. It's considered by many as the imaging reference standard for myocardial infarction and for the assessment of myocardial viability. It's important in the assessment of non-ischemic cardiomyopathies. It improves stress testing performance. And a number of studies now demonstrate that the presence of scarring or infarction on delayed enhancement imaging predicts poor outcomes. For example, this is a figure from a paper that described unrecognized non-Q-wave MI by delayed enhancement imaging, and you can see in those individuals with non-Q-wave unrecognized MI that these individuals have worse outcomes than those without MI. In this talk, I'm going to try to cover the basics of imaging, how to handle more difficult patients, image interpretation for viability, some special cases, as well as a new dark blood delayed enhancement technique called flow-independent dark blood delayed enhancement, or FIDDle. For delayed enhancement imaging, the inversion-recovery gradient echo sequence is probably the best validated and the most common variant in clinical use today. It uses a 2D segmented k-space acquisition. It's ECG gated so that image readout occurs during mid to late diastole. It's performed during a breath hold of about 8 to 12 seconds in duration. For infarct or scar visualization, an inversion time is typically set to null normal myocardium. Here's the timing diagram for the pulse sequence, and I'd like to just point out a few things. First, the timing of the sequence is triggered from the R wave of the ECG signal, as you can see here. Imaging readout is typically performed during mid to late diastole. A non-selective inversion provides T1 weighting, and the image is acquired with an inversion time, or TI, to null normal myocardium, as you can see here. The readout window, or temporal resolution, is typically about 200 milliseconds and is controlled by the number of segments acquired, as you can see in this part of the figure diagrammatically. A weight beat or gating factor of 2 is used between inversion pulses to allow recovery of longitudinal magnetization. And here's the weight beat. Selection of the inversion time by the operator is extremely important, as an inaccurate TI could lead to misdetection of infarcts and poor infarct sizing. The TI or inversion time is chosen to null normal myocardium, which is shown in this longitudinal magnetization recovery curve in magenta in color. When the TI is selected such that normal myocardium is crossing 0, normal myocardium will appear black, while infarcted tissue, which is above the 0 crossing, seen here in green at this point, will be bright. Several strategies are available for the selection of the inversion time. The first is manual or operated selected adjustment of the inversion time, which is what we use at Duke. A TI scout, also known as a look-locker sequence, as well as phase-sensitive reconstruction, which is also known as the auto-viability variant of delayed enhancement imaging. Although the 2D segmented fast gradient echo sequence may be the most commonly used readout type, a number of variants are in clinical use today, including those with SSFP or steady-state free precession readouts. Some centers use 3D variants, while others use SSFP single shots or real-time variants. The choice of variant depends upon the patient and sometimes upon the vendor. In our patients, we perform single-shot SSFP delayed enhancement imaging, followed by 2D segmented fast gradient echo imaging. For the next section, I'm going to discuss how we deal with patients who have difficulty with breath holding and patients with atrial fibrillation. A typical implementation of the delayed enhancement sequence requires 8 to 12 heartbeats per slice. In patients who have more limited breath holding ability, the sequence can be modified to reduce the breath hold time in a relatively straightforward manner. There are a number of different changes that you can employ, and typically we employ a combination of the three I've shown here. First, we change the sequence to employ parallel imaging. You can also reduce the matrix size, for example, from a 256 matrix to 192, and increase the number of case space lines or segments that are acquired per heartbeat. A typical implementation will acquire 21 segments or case space lines per heartbeat. You can increase to this number to a larger number, such as 31. Of course, the downside of this is that it worsens temporal resolution. As you can see here, each of these modifications have a small penalty, but in combination can reduce the breath hold time by up to half. We find that this approach works quite well in patients who can hold their breath for at least 4 or 5 seconds. Of course, there are some patients who cannot cooperate with any breath holding. In these patients, we use real-time or single-shot SSFP delayed enhancement variants. This approach requires an entire 2D image and a single heartbeat. A second method, which is available on some of the newer scanners, is a multi-image averaging with motion correction approach. This method uses motion correction to allow the averaging of a large number of single-shot images in the same slice location. The images typically have higher spatial resolution than the conventional single-shot SSFP approach that I described earlier. And here are 2 examples of patients where these 2 approaches were used. Here on the left is a single-shot inversion-recovery SSFP real-time image, and you can see that there's an infarct involving the infralateral wall. The second image is an example of the multi-image averaging approach with motion correction, and again, you can see that there's an infarct involving the anterolateral wall. You can see just by eye that the motion-corrected image appears to have higher spatial resolution than that of the single-shot inversion-recovery real-time SSFP variant. Now let's switch to patients with irregular heartbeats or atrial fibrillation. Of course, the problem is that the RR interval varies from heartbeat to heartbeat. For example, in this cartoon at the top of the slide, the RR interval varies from 450 milliseconds, as you can see here, to 830 milliseconds. You can deal with this problem in one of two ways. First is to use the single-shot real-time sequence, the single-shot SSFP, or you can use a segmented inversion recovery gradient echo sequence with a few modified settings, which I'll describe in the next few slides. In patients with normal sinus rhythm, of course, we target the imaging readout for mid to late diastole, as this is when the heart is the most still. With atrial fibrillation, this approach, of course, does not work because mid to late diastole is highly variable. However, the timing of early diastole is fairly consistent in most patients with atrial fibrillation. As a result, you can modify the segmented inversion recovery gradient echo sequence so that the readout is targeted for early diastole rather than mid to late diastole. The readout time or tempo resolution is also shortened in order to freeze the motion of the heart, as the heart tends to be less still in early diastole. Overall, these changes reduce artifacts and improve image quality. So how is this done? I'll show you in this cartoon. Again, you can see that the shortest RR interval is about 450 milliseconds. If you set the acquisition window to be less than the shortest RR interval, in this case, we've set the acquisition window to be about 430 milliseconds, the imaging for each heartbeat will occur in early diastole. The number of segments have been reduced to improve the tempo resolution, so a typical implementation acquires about 21 segments. In this case, we've reduced it to 15 segments for a tempo resolution of about 150 milliseconds. So in the next slide, I'll show you how these changes help us clinically. At the top is a set of real-time images in a patient with rapid atrial fibrillation. The arrows point to a possible wall motion abnormality involving the anterolateral wall. The second row shows real-time single-shot delayed enhancement images. And I think we'd all agree that it's hard to be definitive about whether an infarct is present involving this wall. Now next I'm going to show you the modified inversion recovery gradient echo segmented images where we adjusted the readout such that it occurs in early diastole. We also improved the tempo resolution by reducing the number of segments to 15. These unambiguously show that an infarct is present at the base, mid, and distal and anterior and anterolateral wall. If you look at these images, you can see that the infarct, particularly at the base and the mid, is relatively sub-endocardial. And when you get to the distal portion of the heart, it becomes transmural. So with these small changes, you can markedly improve image quality. Now let's switch to image interpretation for guiding revascularization. Here are two patient examples with critical LAD disease, both with akinetic septums, anterior walls, and apices on the cine images, as you can see here and here, as well as here and here. For example, in the first example, the delayed enhancement imaging shows a transmural infarct in the same wall, and thus one could be confident that there's no significant viability. In the second example, despite having similar degrees of abnormal wall motion, the delayed enhancement imaging shows no infarct and thus complete viability. As you can see here, there's no evidence of hyperenhancement. Of course, in example 2, revascularization would be advisable. And I think in both of these two cases, the clinical decision making is relatively straightforward. In example 1, there's transmural infarction, and thus there's no significant viability. Whereas in example 2, there appears to be no infarction whatsoever and complete viability in the LAD perfusion paradigm. How about in example 3? Again, this patient has critical LAD disease and has an akinetic septum, anterior wall, and apex, just like the other two examples. Now I'll show you the delayed enhancement images. Delayed enhancement images show a sub-endocardial infarction involving the anterior wall. So if you look at the anterior wall here, you can see that there's clearly sub-endocardial infarction. However, in some parts of the septum, you can see there's near transmural hyperenhancement. In other words, there are varying levels of viability present within the LAD perfusion territory. Again, the anterior wall seems to have subendocardial infarction, and portions of the septum appear to have near transmural infarction. So the question is, should this patient undergo revascularization? Some of the data that guides our interpretation of these images comes from a paper written by Ray Kim, published in the New England Journal in 2000, as well as another paper by Deep and Shaw that was published in JAMA in 2013. Here's a figure from the paper from the New England Journal. On the y-axis is improved contractility, as you can see here. On the x-axis is the transmural extent of infarction. And what you can see is when the transmural extent of infarction declines from fully transmural to 0, there's a clear stepwise increased likelihood of improved contractility following revascularization. Over the years, I found that this is often confusing to individuals in that it's unclear what exactly is meant by the transmural extent of infarction. Specifically, is it the maximum transmural extent or the mean transmural extent? In fact, the intention of this figure is to show that images should be interpreted based on the mean transmural extent and not the maximum transmural extent of infarction. Why does this matter? In the patient example 3 that I showed you the wall motion in the previous slide, in this patient, the max transmural extent is greater than 75%, as you can see here, here, and here. However, the mean transmural extent of the segments is clearly less than 50% of the LAD perfusion territory. And this is highlighted particularly involving the anterior wall, as you can see here and here, as well as many parts of the septum, as you can see in this part of the septum, as well as this part of the septum and this part of the septum. As a result, this patient should undergo revascularization based on the mean transmural extent, and it would be a mistake to withhold revascularization based on the maximum transmural extent. Based on the mean transmural extent, the patient, in fact, did undergo revascularization. And after 18 months following revascularization, you can see that there's substantial improvement in function with the LVEF returning to near normal. You can see the comparison is quite stark. For instance, if you look at the anterior wall here, you can see after 18 months following revascularization, you can see that not only is the function improved, but the wall has nearly doubled in thickness. Now we'll discuss some special cases, including the interpretation of LV thrombus, microvascular obstruction, and cardiac amyloidosis. A number of studies have shown that thrombi can be identified using delayed enhancement imaging. The underlying principle is that thrombus is avascular and therefore does not experience any appreciable contrast enhancement. As a result, the T1 of thrombus is long after contrast administration and is quite different from blood, infarcted myocardium, or normal myocardium. These differences can be highlighted using high inversion time single-shot delayed enhancement MRI. Empirically, we have found that thrombi null with an inversion time of 600 milliseconds at 1.5 Tesla or 875 milliseconds at 3 Tesla. Thrombi will appear black, whereas other tissues with perfusion or blood will appear gray or bright. This is shown schematically in this figure. Because thrombi do not take up contrast, the T1 is long, and the corresponding dotted inversion recovery curve, which is shown right here, shows that the null time for thrombus is much longer than normal myocardium or infarct. So here's the null time for thrombus relative to that of normal myocardium or myocardial infarction. Using an inversion time of 600 at 1.5 t or 875 at 3 t allows you to visualize the thrombus as a black structure within the heart, while all other tissues are either gray or bright. Here are some examples of different kinds of thrombi in different parts of the heart that can be detected by this technique. This is an example of a left atrial appendage thrombus. Here's a mural left atrial thrombus. Here's a mass-like LV thrombus. Here's a small mural thrombus involving the distal inferior wall and apex. And of course, this is a huge, large mural thrombus that's present within a large LV pseudoaneurysm. Notice that you can see both intracavitary and mural thrombi easily with this technique. The same technique can be used to identify patients with acute myocardial infarction, which is associated with microvascular obstruction. Microvascular obstruction represents obstruction of the microvessels from edema and platelet thrombi or hemorrhage, which prevents perfusion of the infarcted region. There is minimal to no contrast enhancement early after contrast administration, which is then followed by slow contrast enhancement by a diffusion mechanism, which takes quite some time. We identify regions of microvascular obstruction using high inversion time single-shot delayed enhancement imaging. We distinguish these regions from thrombi by acquiring two sets of images, and I've shown you an example right here. The first set is acquired immediately after contrast administration, and the region appears black, as you can see here. The second set is acquired near the end of the examination. In this case, it was 27 minutes after contrast after contrast administration. In the second set, the region of microvascular obstruction here will begin to enhance, and you can see that it now appears quite bright, and the region that was dark is minimal now. A thrombus, on the other hand, will experience no appreciable change early compared to late. Now let's move on to identifying patients with cardiac amyloidosis. In this disease, there is diffuse deposition of amyloid protein within the myocardium. As a result, the myocardium is difficult to know at typical inversion times. That is because there's no quote-unquote normal myocardium present. This is shown schematically in this figure. When diffuse amyloid infiltration is present, there is an apparent left shift in the longitudinal magnetization of the myocardium, as you can see in this orange line. The myocardium is diffusely abnormal with expansion of the interstitial space by the amyloid protein, and thus the T1 is shorter than blood. So here's blood in yellow, and the amyloid-infiltrated myocardium is shifted left of blood, as shown in the orange curve. This is much different than typical patients with or without MI, where normal myocardium has a longer T1 with blood. And just to reiterate this point, so you can see that here's normal myocardium in magenta, and the null point is for normal myocardium is longer than either infarcted myocardium than blood. For our clinical service, we use a TI scout to identify this alteration in gadolinium kinetics, or the Look-Locker sequence. The appearance of amyloid infiltration on a TI scout is shown in this figure. In the orange box, amyloid-infiltrated myocardium nulls at an early inversion time, and you can see that the amyloid-infiltrated myocardium appears dark at a TI of 178 milliseconds in this example. And you can see that this is substantially before the null time in blood, which occurs at 258 milliseconds. Again, this is a markedly abnormal relationship. Again, the amyloid-infiltrated myocardium is crossing earlier than blood, as shown in the schematic. In this figure, I've actually added a figure of a patient without amyloid as the bottom panel, just to give you a comparison between patients with cardiac amyloidosis at the top versus patients with myocardial infarction or normal at the bottom. You can see that, again, in patients with amyloid infiltration, the amyloid-involved myocardium crosses at an earlier time point than blood. However, in a patient with or without MI, blood crosses earlier than myocardium. Once you identify that amyloidosis is the diagnosis by using a TI scout, then you can then perform conventional segmented delayed enhancement imaging to demonstrate the distribution of the amyloid protein. To highlight the amyloid-involved myocardium, use an inversion time to null the blood. The enhanced myocardium represents the regions with the most amyloid deposition. So again, to reiterate this point, what we do at Duke is we set the inversion time to null blood. Because the amyloid infiltrated myocardium has shorter T1, it recovers more quickly, and as a result, those areas will appear bright on these images, as you can see in the slide to the right. Now I'm going to discuss a new dark blood delayed enhancement technique called FIDDle, or flow independent dark blood delayed enhancement, that we believe will supplant the conventional delayed enhancement method in the near future. Although delayed enhancement MRI is the imaging reference standard for the diagnosis of MI, there are instances where it can be ambiguous. For example, you can see this in example 2. So this is a patient who experienced a myocardial infarction, and the LAD was occluded on coronary angiography, and the question is there a clear infarct present? I think we'd all agree that it's somewhat ambiguous. This may not be altogether surprising, as a recent multi-center study demonstrated that up to 21% of chronic non-QA infarcts could be missed by the delayed enhancement technique. You can see that here. This may be because the infarct and the cavity are often bright, as you can see in example 2, and sub-endocardial infarcts could be hidden by the lack of contrast between the bright blood pool and the bright area of infarction. Flow-independent dark blood delayed enhancement, or FIDDle, was developed to overcome this limitation. And this technique provides simultaneous blood suppression and visualization of contrast enhancement. Since the blood is dark, it markedly improves the visualization of the infarct that is adjacent to the blood pool, as you can see in these two sets of images from the same patient with history of non-ST elevation MI. So here you can see that on conventional delayed enhancement imaging, it's difficult to discern whether or not an infarct is present. These are FIDDle images from the same patients, exact same slice locations. And you can see because the blood has no signal, you can see that the region of enhancement is clearly visible adjacent to the gray normal myocardium. You can see this both in the short axis view as well as in the long axis view. The technical details of this sequence have been recently published in this paper in JACC Cardiovascular Imaging. So I'm not going to go through these in great detail, but the components include a preparation pulse that affects magnetization of myocardium differently than blood, an inversion-recovery pulse, phase-sensitive reconstruction, and an inversion time selected such that the blood magnetization is less than tissue magnetization. Now I'm going to show you how this could help us clinically. Here are two subjects from the validation study with myocardial infarction. In subject 1, FIDDle and delayed enhancement show regions of hyperenhancement that match the pathologic gold standard. So here you can see a clear region of delayed enhancement. It's matched very well by the fiddle image, and you can see that on histologic staining, the region of infarction, which is here, matches almost perfectly with both the fiddle and the delayed enhancement image. In subject 2, however, there's no clear infarct present visualized on delayed enhancement imaging. However, on fiddle, you could see that there's a sub-endocardial region of hyperenhancement involving the anteroseptum and the distal anterior wall. And you can see that this is well matched by what we see by histologic staining here. Now I'll show you 2 different patients with anteroseptal wall thinning. On delayed enhancement imaging, it's not quite clear if hyperenhancement involves the anterior septum. You can see here versus here. Is there hyperenhancement? On the fiddle image, you can see in fact, only patient A has a region of hyperenhancement, whereas patient B, which was a normal control, has no region of hyperenhancement. In fact, this patient had no coronary disease, whereas the patient A, where the infarct is present, the infarct-related artery was the LAD, so these 2 things corresponded well. What about patients C and D? Is a lateral wall infarct present on conventional delayed enhancement imaging? Again, I'd say that's fairly ambiguous. Here again, however, only one has evidence of MI on fiddle. That's patient C, as you can see here. Patient C experienced an infarct in the left circumflex coronary artery, whereas patient D was another normal control. What about patient E? Is there an infarct present? I'd say again, it's fairly ambiguous whether an infarct is present within the heart. However, on the fiddle image, again, you could see a rather extensive but entirely sub-endocardial infarct in the LAD perfusion territory. As you can see, we're quite excited about the potential for this technique and have been using it in our clinical service, and we hope that will become more widely available soon. To conclude, I hope you found our discussion useful. Delayed enhancement MRI is a core part of the clinical cardiac MRI exam. And you can see that it can be used for the assessment of MI, viability, and cardiomyopathy. It's used as a component of stress perfusion MRI and in the assessment of intracardiac thrombi. Straightforward optimizations can substantially improve image quality. New techniques such as fiddle may improve diagnostic performance further. If you have any questions or are interested in further training opportunities, please visit our website. We have online education and level 2 cases, observerships, and fellowships. We also offer a 1-week intensive CMR course in April and in September. And if you have any questions about any of these things, you can contact me or Michelle Parker at these email addresses. Thank you for your attention.